Good morning, Chris. Thank you for joining me today as we talk about the hyperbaric medicine and the continuing medical education that we're doing here at St. Lucia.
Oh, it's so awesome to be here. I've been a member of DAN since the 1980s, so I'm happy to still be a part.
That's great.
Yeah.
So, first question for you. What brought you to diving? When did you become a diver?
Yeah. So I always tell everyone, much to my parents' chagrin, that life began for me in 1985 when my father signed me up for a scuba diving class at the local dive shop in Buffalo, New York, Dip and Dive. I'll give them a shout out. And then I spent so much time at the dive shop that the husband and wife team that owned the dive shop basically adopted me, and that was I never really worked a day in my life because that was my first job, was working in the dive shop. So I started mopping floors, filling scuba tanks, and then I progressed up to dive master and scuba instructor through the dive shop when I was in high school and college.
Okay, very nice.
Yeah.
And then you're here as faculty. Your background is in medicine. Tell us about your background in medicine.
Sure. So I went to medical school in Buffalo, the State University of New York at Buffalo, and then I did my emergency medicine residency in North Carolina at East Carolina University. And then when I graduated from emergency medicine residency back in the early 2000s, it was the first year that undersea and hyperbaric medicine became a fully accredited fellowship training program. So I snuck into the fellowship program at the University of Pennsylvania in Philadelphia, did my fellowship in diving and hyperbaric medicine. So I'm an emergency medicine doctor that also does diving and hyperbaric medicine.
So as you were doing your schooling, you were already going into diving as a specialty of something that you were working on. Is that right?
That's correct. Yeah. So I got my undergraduate degree in biophysics, and I spent some time between college and med school working in a hyperbaric lab doing diving medicine research at the Center for Research and Education in Special Environments in Buffalo, New York. It was Dr. Lundgren's old lab that I got to work at as a research tech and assistant. So I was also a chamber operator and a research assistant in the lab before I went to med school. Yeah.
So this week you're here talking about several topics. What are some of the topics you're talking to the doctors about this week?
Sure. So one of my big interests is in medical evaluation for diving. We have a robust dive medicine clinic at HCMC in Minneapolis where we make sure it's safe for recreational divers, commercial divers, and local scientific divers to make sure that they're safe and mitigate risk when they go diving. And then I'll also be talking about some clinical hyperbaric medicine. We have a very busy hyperbaric program at Hennepin County Medical Center using hyperbaric oxygen pressure and oxygen to treat many different disease conditions.
So when you talk about forms that can be filled out and how to decide if somebody has the fitness to dive, what are some of the things on the forms? We maybe all saw the original form. Are there things that you guys are looking at changing?
So the form's been it's an evolving progress. It changes over time based on different things. Like during COVID, they had to add some things in there about COVID. Anybody who's taken a scuba course has had to fill out that form where they check the boxes, and that form will screen for things like heart problems and lung problems if they're on any special medications and that types of thing. And if that form requires them to see a diving medicine physician, then they'll see a doctor who's trained in diving medicine like myself or other people who are taking the course here.
Would you have any advice to give to a dive instructor that the diver comes up and starts asking questions about the dive medical? What should a dive instructor do if their diver is asking questions about it?
Yeah, so what they should do is call Dan, right? So the Divers Alert Network is a resource. We all call Dan, even the physicians call Dan to gather information or share information with them. So calling the Divers Alert Network. What I do as a diving physician in my local area is we try to do a lot of outreach to the local dive shops and to make sure that they know that we exist and we can be a resource to them. So if the scuba instructor has questions, they can give us a call. Okay. They have our card in their at their dive shop, and they can give us a call and we can answer questions for the divers.
So you said you're also talking a little bit about hyperbaric medicine. Tell us, to the person who doesn't know what that means, what is hyperbaric medicine?
Yeah, absolutely. So what I tell patients and physicians who don't know much about what we do in hyperbaric medicine is that we're actually administering a drug. That drug happens to be oxygen. The only way a human being can get a high dose of oxygen in their body is to breathe 100% oxygen while they're at elevated pressure. So I need the chamber to increase the pressure in the environment, and then they breathe the oxygen. And when I can do that, I can get their blood level of oxygen 10 times higher than I could if they were just breathing oxygen on a mask in an ambulance or an emergency room. So we're giving them a high dose.
So when you talk about bringing them up to pressure, what kind of pressures are we talking about?
Yeah, so we will have, it's interesting because those recreational divers that dive nitrox are taught not to breathe too much oxygen, right? So we talk about maximum operating depth for nitrox and that type of stuff. And when they come to the chamber, they're like, you're doing what? Because we will typically have our patients breathing 100% oxygen at depths equivalent of 45 feet or 60 feet, which is 2.4 to 2.8 atmospheres. So that dose is much higher than we would accept the risk in the in-water environment, but we're not as worried about the consequences of neurological oxygen toxicity, and the rate is still pretty low in a chamber that we can deliberately give those patients that high dose of oxygen so we can get the benefit of the drug to treat their underlying disease condition.
I've heard people translate that a little easier for divers to understand. 2.8 partial pressure of oxygen. What kind of, can we think about a depth that would make sense as
right.
It correlates to a depth?
Yeah, it depends on what gas you're breathing, right? So it depends on what nitrox. So that would be breathing 100% oxygen at 60 feet. We would have to do the math on, if I was breathing a 32% nitrox mix, how deep that would be. The actual depth we're taking the patient to is 60 feet. They're breathing pure oxygen at 60 feet. We would never do that in the open water. It's too deep. Our risk for seizure is pretty high.
So the pressure in the chamber is the same as if I was at 60 foot of water.
Exactly. Yeah, exactly.
So when a diver comes to your facility, they're probably quite nervous. What would be some of the things that they would be presenting? What would be the signs and symptoms that would say to you they should go into the chamber?
Sure. So the signs and symptoms of decompression sickness would include, the most common symptom would be joint pain or these odd numbness and tingling sensations that can be in different patchy areas that sort of are unusual. A skin rash can occur. So there's a particular type of rash we'll look for. So those are the types of symptoms we'll look for in someone who's suffering from potentially decompression sickness. And decompression sickness typically will occur sometime after a dive as your body's trying to unload the nitrogen. Other emergencies where the patient's usually in a little bit more extremis is if they've had a rapid or uncontrolled ascent to the surface and they've suffered a lung expansion injury and gas has escaped the lung and gotten into the arterial circulation and gone somewhere like the brain and caused stroke-like symptoms. Those people are usually a lot sicker and will appear by ambulance or be coming to the chamber emergently for treatment.
So if the chambers are oftentimes used for things other than divers,
Absolutely.
right? What are some of the other things that they might be?
For sure. Yeah. So we are, again, we're delivering a medication. That medication is oxygen. Oxygen only at high pressure does a couple of different things for you. What I tell people is I'm in the business of potentially healing wounds in people, but not every wound. It's folks who have wounds that are related to what we call microangiopathic disease, or the small blood vessels have been damaged over time from a disease process. And then the body in that area is not getting enough oxygen or nutrients to that area, and therefore they will develop a wound. The two big patient populations we treat are the diabetics with lower extremity foot ulcers. If people know people who have had diabetes for a long time, they tend to get an ulcer on their foot, and that ulcer won't heal, and then unfortunately they can go on to require an amputation, and it can become life-threatening for them. We can get those wounds to heal by using the oxygen to grow new blood vessels in that area. The other second big patient population we treat are the radiation-injured patients. So a patient's had cancer. They received radiation treatment as part of their cancer. Hopefully their cancer is gone and they're in remission, but the radiation has left the tissue in that area damaged. A lot of head, and I'm pointing to my head and neck because it could be in the head and neck area. And so the radiation has damaged those small blood vessels, and then a wound will develop, or a surgeon needs to go in and do a surgery on a tooth or in that area, and the post-surgical wound won't heal very well. So that we can treat those patients with high-dose oxygen to get those wounds to heal, again, primarily by trying to grow new blood vessels and stimulating what we call angiogenesis, or the growth of new blood vessels in a site that's not healing well. So
it's amazing what hyperbaric chamber can do
so
for the human body.
But at the end of the day, they're all diving. So these patients are, we get back to diving, they're all diving. They're just diving on pure oxygen. So you still have to know your basic physics and physiology like all of our divers do. Many of the divers that I see know more about diving medicine than the doctors I'm standing next to who've never experienced it. So it's fun to interact with the divers. So I'm one of them. So
one of the great things about coming to a course like this is getting to chat and visit and talk about all these things after hours. So last night you and I were talking quite a little bit about our ears.
Yes.
So if you're in a chamber, do you still have to clear your ears?
You do. So regardless of whether you're in the water or in a chamber, the pressure's still going to build up. So as divers, we have to equalize our ears as we descend. Same thing when the chamber is pressurizing, you have to equalize your ears in there too. So when I have patients that have to go in the chamber, I have to teach them how to clear their ears, like I do when I'm a scuba instructor teaching a new diver how to clear their ears. So.
And as we were talking last night, it is often one of the more common injuries for divers because they don't understand how to clear their ears, or perhaps they push too hard. What advice would you give to the dive instructor about how to teach their divers?
Yeah, absolutely. So, and by the way, it isn't just divers. Anybody who goes in hyperbaric chamber, so the doctors, the nurses, the technicians, all the patients, we all have the same issue. We all have to be able to equalize our ear pressures when we go in. So as a scuba instructor, I try to spend a lot of time talking to the divers about ear equalization as I'm teaching them. And then because we often do our initial pool sessions in a pool that's not very deep, oftentimes we aren't able to tell if a diver is really having trouble or not. So we want to make sure we go through the different techniques for equalizing their ears, not just the Valsalva maneuver. Maneuvers like swallowing while you're pinching your nose will do it, or making a sound or something like that will help you pop your ears. So there's a couple different techniques that you can use aside from Valsalva maneuver. I also want to make sure that we tell our divers too that a lot of people like to do a Valsalva maneuver. You never want to do a Valsalva maneuver while you're ascending. So oftentimes if you're descending in the water column trying to clear, if you can't clear, you'll go up a few feet. Don't Valsalva while you're going up. Wait till you go up and then retry to do a Valsalva maneuver, or you'll potentially cause overexpansion of your lungs if you're holding your breath or bearing down while you're ascending. So that's another thing we want to teach our divers is not to Valsalva during a pressure reduction or during an ascent.
You said just a little bit about a couple of other techniques. Give me the name, because they have fun names.
Yeah, they have fun names, yes.
And give us a little more about what it is, what each of those are.
So the Frenzel maneuver is where you can pinch your nose or close your nose in your mouth and make a k or g sound. It's named, Frenzel was a Luftwaffe pilot during World War II for the Germans, and those pilots had an unpressurized airplane, so he was teaching his fellow pilots how to equalize their ears as they went up. And then the Toynbee maneuver is a maneuver where you're swallowing while you're pinching your nose but not blowing, and the forceful movement of your tongue pushes air up through your eustachian tube. So those are a couple of different ways. But in general, the muscles that help you equalize your middle ear space and open your eustachian tube are mostly affiliated with swallowing. So if you can, it's kind of tricky swallowing with a regulator in your mouth, so that's hard to do sometimes, but wiggling your jaw and trying to swallow will help, or making that sound while you're pinching your nose.
So why are there different techniques? Why wouldn't one technique work for everyone?
Yeah, everybody's different. Everybody's anatomy is a little bit different. I have some people that can equalize their, as you know, there are some divers that they don't look like they're doing anything and they're equalizing just fine. So it really depends on your anatomy and what works best for you.
Do you have a favorite?
So I can actually equalize my ears by just breathing through my nose. So I have my eustachian tubes must be pipeline. So my favorite parlor trick is we did bring the video otoscope with us on the trip. And I can put the video otoscope and you can see my eardrum on the screen, and I can breathe through my nose and my eardrum will move back and forth. I must have gills, or so. I was meant to be in the water. My eardrum will move back and forth like that. So some people can do it that way. So I can do it by just blowing a little bit of air in, or inhaling or exhaling through my nose in my mask will pop my ears for me.
So the course we're at this week, continuing medical education, is mostly doctors, mostly medical folks in the room. What would you tell the diver? What is the benefit to a diver? What would they want to know about a class like this?
Well, so, I mean, we're talking about, at the end of the day, I mean, we're going to throw around a lot of fancy medical terms, but at the end of the day, we're talking about diving. What happens when you dive from a physiological standpoint? And like I said, I know a lot of divers who know more about diving medicine than some of my medical colleagues, because in medical school and even in residency training, you don't get a lot of training specifically related to the diving environment. That's why we have fellowship training programs, and that's why we have CME courses like this, so physicians can learn and but we're also talking about the stuff divers experience every day. Want to keep them safe.
So Dan has a mission to try and make every dive accident and incident free.
Yes, I love it.
You've been teaching these courses for several times, but prior to that, what was your experience with Dan when you were a dive master or a young diver?
Oh, Dan was always an excellent resource. Dan has medics who are on, so there's an informational line and then there's an emergency line for Dan, and you can call that informational line and they have access to information. So if you have a question about any diving related stuff, you can get on the horn during normal hours during the weekdays and talk to someone about that, and they can give you that information. In addition, if you're traveling somewhere, Dan keeps an updated list of active clinics and chambers that can help treat divers. So oftentimes we'll check to see, which chambers are available near where you're going. And you should always try to, when you go on a trip, especially to a remote location, sort of imagine if you had a medical issue or problem, what would you need? What resources would you need? And really it's variable depending on how remote that location is. So something good to think about before you go on the trip and not wait till something happens and then have to worry about it. Preparation helps. So
it's great. So you are involved in active research and active studies of new things. What is your next thing? What are you interested in looking at next? What are you studying?
Yeah, so I live in two worlds. I live in the clinical hyperbaric medicine world and the diving medicine world. You and I spent a lot of time talking the other night about ear equalization, and I'd like to wage war on that disease process, or making sure all divers know and are taught really well how to clear their ears so we have more of them to continue diving. But in the clinical hyperbaric medicine world, we're in the middle of a NIH-funded phase 2 adaptive clinical trial looking at the role of hyperbaric oxygen, high-dose oxygen, in acute severe traumatic brain injury. So these are people who have been injured badly, motorcycle crashes, motor vehicle crashes, where they're near death from head trauma. They're very sick. They're often mechanically ventilated. A tube is breathing for them, and they need to go to the intensive care unit. The neurosurgeon often has to put a device in their brain to measure the pressure in their brain so it doesn't get too high. But one of the other things we found is if we put a brain tissue oxygen meter in the brain, we can tell that the brain's not getting enough oxygen and it's very stressed. And we can fix that problem by taking that patient and giving them high-dose oxygen in the hyperbaric chamber. So the depends on whether you want to call it the Hobbit or the Hobbit trial, the hyperbaric oxygen for brain injury trial. We're about 3/4 of the way through. It's a multi-center trial, 12 sites across the country who are enrolling patients. And we're going to gain a lot of information from that study, and maybe a new role for using hyperbaric chambers and hyperbaric oxygen to help people survive traumatic brain injury, and not only survive, but survive with good neurological outcomes. So that's a project that's been a labor of love, but near and dear to my heart as well.
So we are here with all of us having a love of diving.
Yes.
Tell me a little bit about your favorite diving experience. What was your favorite diving experience?
Sure, yeah. So hard to, so I spent a lot of time in the diving industry as a dive master and scuba instructor, but I cut my teeth diving in the Great Lakes. So in Buffalo, New York area. So diving in places like Tobermory, Lake Huron, Lake Ontario. One of our favorite dives to do is a Niagara River drift dive, where you dive in the Niagara River above the falls. So it sounds more scary than it is, but you'll actually drift. It's like a drift dive, but in the river. And we would do it. Grand Island is an island with the Niagara River splits around, and we would do it on the northern side of Grand Island, where Canada's on the other side. So we would do a drift dive, and we would kind of cross the border but not go through customs underwater. And during Prohibition, they used to run whiskey across the river, and if they got caught, they would throw the whiskey bottles down. And I actually found a full bottle of Prohibition whiskey on a Niagara River drift. That's one of my favorite famous claims to fame. And that bottle of whiskey is still in the dive shop, in the front of the dive shop where I learned how to dive. So
how funny.
So I did that. But we did ice dive. I was an ice diving instructor. A lot of shipwreck and wreck penetration, because that's what we like to do in the Great Lakes. And then I've also traveled the world. I'm cave certified. So I did cave diving in the Yucatan and in Florida. And then, being in St. Lucia is wonderful as well. So I like to dive anywhere I can get wet and put on some scuba gear. So
a lot of times people have an offshoot that they like: photography, videography, wrecks, cave. Do you have a favorite offshoot?
I'll be honest with you, I just like being underwater. Like, it's as simple as that.
Pretty darn relaxing.
It's it's the closest thing to meditate. You know, when you talk about meditation, you talk about focusing on breathing. Where else can you go where it's quiet and all you hear is your own breath, right? So I like being weightless and I like being underwater. So I can take pictures, but it's the sensation of being there that never gets old. So,
yeah. So the question every diver is going to ask you, how long can you stay down?
Right. Yes. A breath hold diving or no? Yeah. Right. So yeah.
How long is a dive?
Yeah. How long is a dive, and that depends on how much gas you have and how deep you go. Right. So that's non-divers would ask those questions, right? So, but we as divers know. So that depends on what your mission is and how much gas you brought with you. So.
And you talked about cold water diving. So here's another metric everybody talks about.
Yes.
What's your coldest dive?
Coldest dives, 37, 38 degrees on the bottom.
What were you wearing for an exposure
A
suit?
dry suit. So we it's funny when we would train divers in the Great Lakes, everyone would start out with a wetsuit for like a couple of trips, and then everyone would go to a dry suit after that. So I still have my trusty dry suit, and I will use that. Now the temperature moves up to where I use the dry suit. So if it gets up into the low 70s, I'm thinking about it. But back in the day, that would have been fine. So yes. So dry suit diving, and then you know, one of the things we worry about in cold water diving is regulator free flows, right? Freeze ups in there. So it's again important for us to talk about safety and what to do if a regulator freezes open. So we spend a lot of time training on that and making sure people know what to do and think about what type of regulator you might be using in that environment so that it's less likely to.
So that's equipment. That's interesting. We've been talking a lot about physiology. Yes. What does it do to your ears, cold water?
Cold water, you're oftentimes wearing a wetsuit hood, and that wetsuit hood needs to fit you properly. You want to make sure it's not pushing too hard on your external auditory canal, because you can trap air in the outside of your ear. But also in cold water, people tend to get stuffier or have more difficulty equalizing. So you want to pay attention to miliary equalization like you do on all dives, but in cold water that will happen sometimes as well. Or if you get congested during the dive from the cold water, you have to be careful during ascent at the end. So.
Well, Chris, I very much appreciate your time today. Thank you for coming to beautiful St. Lucia to be one of our faculty, and thank you for letting me interview you.
Pleasure to hear. Safe diving always.
Safe diving always.
All right, sounds good.